All right, why don't we go ahead and get started. So welcome to the final panel for the Equality, Opportunity, Public Policy in America course. This is the final of our panels. The first one was on education policy, the second was labor markets, then safety net policies, and now here we are at health policy, and in particular health equity in the state of Iowa. So without further ado, I'm going to turn it over to our esteemed panelists. We have asked them to both introduce themselves, the organization that they work for, the role they play, the role their organization plays in terms of health policy and health equity, and then we're going to turn it over to you guys to ask some questions. So without further ado, help me welcome the panel.
Hello everyone, and thank you so much for having me here tonight. My name is Barbara Vinograde, and I am the Executive Director of the Iowa City Free Medical and Dental Clinic. And I think the first thing I'd like to say is I'm honored to be sitting at this table with this group of women here, who I think are going to add a lot to what I have to say. I have worked with the Iowa City Free Clinic for 24 years. My current role as the Executive Director I've held for 4 years. The 20 years prior to that, I served as the Director of Clinic Operations. And in that role, I worked directly with our patients. I coordinated the clinics and the patient care. And that role really gave me so much information and assistance in the role I currently play at the clinic, where I am responsible for the overall operation of our clinic. And that includes the financial management of the clinic, the personnel management, the services we offer, and the public outreach we do, such as speaking to all of you. I don't know how many of you are familiar with the clinic, but I would like to share a little information about our organization and what we do today, the people we're providing care for today. I did bring some information with me. If any of you would like additional information after the presentation, after the class, please come up and I'll be glad to share some additional information with you. The clinic is governed by a board of directors, and we employ 4 full-time employees. I'm one of them. We also have 2 half-time employees and 5 very part-time employees. Obviously, we can't do what we do with that number of people. So we have over 200 volunteers who work with us. They're from a wide variety of disciplines, ranging from physicians and dentists to pharmacists and lab techs, specialists. We have a lot of interpreters and receptionists, and people who just help with office work as needed. The Free Clinic was founded in 1971, and I'm proud to say we are the 2nd longest running free clinic in the United States. We are second only to the famous Haight-Ashbury Clinic in San Francisco. There were clinics that were free clinics that were started before 1971, but they had to discontinue operations for a number of years since then due to lack of funding. And we have been very fortunate in our community in that we have been able to establish incredible and invaluable partnerships with many, many organizations. And this has allowed us to run as long as we have. The clinic was founded in 1971 on the principle that access to health care is a basic human necessity. And that foundational belief continues today. In our 45 years of operation, obviously we've seen a lot of changes at the clinic. We've seen changes in where we're located. We've seen changes in the services we offer. But the mission of the clinic has remained constant, and it remains relevant today. And our mission is to provide quality, comprehensive healthcare services for the uninsured and underinsured in Johnson County and surrounding areas. As far as a public health perspective, the clinic serves as Johnson County's public health clinic. It serves as Johnson County's community health clinic. And as such, It really plays an important role in public health because it provides free access to a wide range of comprehensive services for a very low-income, vulnerable, and diverse population. Today at the clinic, we offer 6 weekly medical clinics. 2 of those weekly clinics are for patients with acute illnesses, and by acute I mean an immediate concern such as an upper respiratory infection, an ear infection, someone in need of a job physical, or in need of a check for sexually transmitted infections. 4 of our weekly medical clinics are geared for people with chronic health conditions, especially diabetes and hypertension. We also hold between 5 and 8 monthly dental clinics where we offer exams and x-rays, treatment plans, fillings, extractions, and hygiene. And the number of dental clinics we're able to offer is based on the number of volunteer dentists that we have. We have an on-site medication dispensary, we have an on-site laboratory, and we also offer other specialty clinics in addition to the dental services. We offer ophthalmology clinics on a monthly basis, dermatology, physical therapy, and gynecology. I have a lot I'd like to share with you, and you had a lot of questions for us about the Affordable Care Act, but what I'd like to do at this time is just tell you who we've seen at the free clinics since the implementation of the Affordable Care Act. We are seeing primarily 3 groups of people. We're seeing people who are unable to find an affordable insurance plan, even with subsidies that are provided through the ACA. We're seeing people who don't qualify for an ACA plan. A lot of our patients are people who are new to this country, who are here legally, but who have not lived here 5 years. And because they haven't lived here 5 years, they don't qualify for assistance programs through the law, the expanded Medicaid in particular. We also see a lot of people who I call underinsured. This includes people who have insurance, but the insurance covers a limited number of services. For example, they may not have any dental care coverage. They may not have coverage. We see a lot of people who need ophthalmology exams and other specialty care exams. I also include in the underinsured people who have insurance but can't afford the ongoing costs of the premiums, of the co-pays, of the co-insurance, and of deductibles. It's really important to recognize that for low-income families, deductibles can be a really major expense. The underinsured that we also see also include people who, for reasons of affordability, choose insurance plans on the marketplace that are called the bronze plans. These are ones that have lower premiums, but often but as a result of that, come with higher co-pays. And these can be difficult to maintain, especially if you have a chronic illness and you have to go to the doctor on a regular basis. And finally, the underinsured, I include people who, for reasons of affordability, choose to purchase the catastrophic coverage only, which, as the name implies, only covers very major illness if someone gets sick. I think that's all I'll say for now. Again, I have a lot more information I'd like to share with you about the ACA and how it's impacted us, but I think I'll pass on the mic to our next speaker.
Thank you, Barbara. My name is Eleanor Lisa Lavali Gomez. I'm a family physician here in Iowa City. I'm a transplant to Iowa. I moved to Iowa in 2002 from New Mexico, born and raised. Very proud. I graduated medical school in 2007. I actually moved to Iowa to gain residency so that my medical school tuition would be reduced in half. So it effectively cut my debt from $200,000 to $100,000. I'm still paying on that. Upon graduation from medical school, I did residency at the Cedar Rapids Medical Education Foundation for 3 years in family medicine, and from there I matriculated to the burgeoning metropolis of West Liberty, and I practiced in West Liberty for 5.5 years in primary care. I found myself in the throes of physician burnout, and with the expectations that in private practice I would be seeing 25 patients a day approximately. There were pressures to see more. My income was volume-based, so the more that I saw, the more that I would earn. The less that I saw, that could potentially implicate my salary the next year. So if I didn't meet quotas, I had the potential to lose several $1,000s in my salary just because I wasn't as productive. There were times where when I met with an administrator to negotiate for a higher salary after being in my job for 5 years, and he told me, well, your productivity is flat. We don't think that you should be making more. Actually, we should cut your salary. And I felt that after 5 years, I had gained experience. I had built a practice. I'm bilingual. I had a very loyal patient base. And I told him, well, you know, I have these attributes that I think I'm worth my salary and more and a raise. And he said, no, well, we're just going to keep you where you're at. You should feel glad that you are where you're at. He said, you know, I really like the community that I work in. I like my patients, but I could also find another job. And he gave me a 6% raise on the spot. I stayed with that position for a few more months, but I couldn't take it anymore. I'm a mother to 2 children. I have a 3rd grader and a kindergartner, and I'm married. I have a lot of interests outside of medicine, but I was losing the passion for medicine, and I decided I really would like to give back. And I actually was a medical student and rotating through the free medical clinic. And it's nice to see Barbara again because it's full circle. You know, you see faces in the community and you recognize, or you may have seen another person in a similar situation through your path. So I decided to pursue an academic position at the University of Iowa. And I was glad to find an opening. I work at the Southeast Iowa City Clinic. I work full-time, 8 to 5. I have 4 full-time clinic days. 2 days are unscheduled where I do administrative work. That means filling prescription refills, answering lab requests, etc., all the administrative things. And I also do obstetrics. I do help in labor and delivery and help as part of the teaching mission of the university that way. So my path to this point here, as far as advocacy and what we're talking about as far as equity, I think has been in place for a long time. Ever since I was a volunteer in the free medical clinic, I've always felt the importance of giving back to your community and using your time and your treasure. I do donate to charitable causes, but your talent as well, and I found that that has gone a long way. A year ago, a friend of mine, who is currently the president-elect of the Iowa Academy of Family Physicians, said, hey Lisa, would you like to come to this meeting in Kansas City to be the minority delegate? I didn't know what that meant, but I thought, well, I'm a minority. I guess, I'll show up and see what I can do at this meeting. And this meeting is part of the American Academy of Family Physicians, called the National Conference of Constituency Leaders. And I thought, okay, I'll just show up, wear the name badge, see what's going on. I thought I would be a wallflower for the 3 or 4 days of this conference. And within 4 days, I had written my first resolution that was presented to a policy-making body within the Academy to better something about my situation. My situation at the time was, how do I negotiate myself better within my profession so that I get the salary that I feel like I deserve? And because of that, I think that's how I ended up at the university. I made a job change because of that. The National Conference of the Constituency Leaders is a group of family physicians that come together to advocate for ideas that are important to us as physicians, but also for our patients. So this last year, I wrote a resolution to encourage the American Academy of Family Physicians to support implicit bias training for residents. It would allow us to learn about what are our biases that we hold that we don't know that might affect how we treat patients. There are a lot of studies that show that if you're African American in the emergency room, there's a good chance that you're not going to get adequate pain relief if you are compared to a minority patient with the same presenting complaint, such as appendicitis, for example. So I found that there was something that I wanted changed. I learned how to make that change by using the language that we propose at these meetings, conferences. And from this meeting, I was elected to be a member constituency alternate delegate to the Congress of Delegates, which is the largest policymaking body of the American Academy of Family Physicians. So next year, I went this year as an alternate. Next year, I will go as a voting member to vote on resolutions that will impact all of us in some way or another. I'm very proud about this. I'm passionate about advocacy and leadership. This meeting, the NCCL, was a fast track to leadership. I've learned a lot, and I'm very anxious to continue my work for advocacy. One of the questions that we were asked to talk about as far as what are some of the biggest health equity challenges facing Iowa. In my practice in the Southeast Clinic, I see many Spanish-speaking patients that have followed me from West Liberty. Many of them work in meatpacking plants. They come from Columbus Junction and Tyson. They work at West Liberty Foods. They many times are undocumented. They work long hours. They go into a job and I say, what's your work shift? When I'm trying to get a feel for their work, they say, well, I go in at 7 and I don't have an exit time. I work till the boss says that I'm done. When was your last vacation? I work 7 days a week. I haven't been to my home country for 12 years. When do you have breaks during your work shift? Well, it's cold where I work, and the line work is really fast, so I really don't get a chance. I don't have time to go up to my locker to use my insulin for my diabetes. When was the last time you had an eye exam? I don't get time off from work to get my eye exam. So you can see some of the challenges that I experience being on the front line, seeing how my patients are affected by maybe difficult access to care, working in jobs that don't allow them for more time to take care of themselves, to eat well, to exercise. These are all the things that I like to promote as far as their health. I also care for a growing immigrant population here in Iowa City. There's a significant growth of the Congolese population. Many come from the Democratic Republic of Congo, some by way of Tanzania, and by many other countries, they're refugees. And I know that Will Story, who's in the Department of Public Health, has estimated that just last year there were approximately 240 refugees coming to Iowa City. And we care for many of them. There are many barriers to their care. Barriers as far as language. They speak Swahili, they speak Kirundi, they speak languages that I've never heard of, that I can't communicate in. They speak French. I speak Spanish, but French and Spanish don't get very far. Can you imagine when a woman is in labor and we have an interpreter phone and I'm trying to ask her, can we, facilitate this part of your labor, and she's in pain and she doesn't know the language, and those barriers that would present itself. And there's been many situations that have arisen because of the language barrier itself, in addition to cultural barriers. Many of the Congolese women fear having a cesarean section. They think, oh, it's the doctors that want to get more money, refuse cesarean at all cost. If a baby needs to get out quickly, and a cesarean can save that baby's life, sometimes it's the best way to assure the health of the mother and the child. But there have been untoward circumstances and consequences when there was fear involved in that decision making, and there was a bad consequence in the health of the newborn. So these are some of the things that I see on the front line. I'm happy to answer any of your questions. I'll let our next panelists talk a little bit about how they participate.
Hi. I could double microphone, that would be something. I can talk loud enough already, you don't need me with the microphone. I'm kind of sitting in two seats tonight, and I'll tell you about one that I work away from the university. My husband is a family practice physician. We practice out in Amana, Iowa. We have a practice with 3 physicians and 2 PAs in it, and we just opened a new clinic in Tiffin. There's my advertising plug, where we have an ARNP and a physician and a couple of PAs working. We are a proprietary clinic that works primarily off of people who have insurance. We keep our patients if they lose their insurance and they cannot pay, but we don't keep patients who refuse to pay or make any kind of payment. So if you were one of our patients and you did not pay your deductible or your co-payment, and we asked you to make a $5 a month payment on that and you did not make it, we would terminate you after 6 months. You could come back and pay your bill, but we would not keep you, so you might end up over at the free medical clinic when that happens, if you have that as an access point. We have integrated some things into our clinics to try to make it easier for people to come into the clinic and make it more comfortable. So we're, I believe, the only clinic in the state of Iowa where when you come in, you do not sit on an exam table to see your physician or your PA or your ARNP. You'll go in the first part of the room and there's a table with chairs around it and you talk to the provider for the first part of your visit around a table. Surprisingly, in the first 3 months that we've implemented this model of starting at a table, talking to a provider, we found out that half of the time, our providers never need to go to an exam table because they're dealing with things like depression or medication reconciliation or diabetes where people need counseling. They don't need a full physical exam. Sitting at a table, you can take somebody's heart rate. We have a scale for them to be weighed. You can take their blood pressure. You can check their feet. So a lot of things can happen in that equal area that's called a table where you sit at an equal level rather than on the exam table where you're on the table and you're kind of in a position of having the physician be the authority or the provider. It's unequal. So we think we've got a good model there. That's one of the things that I do. Not probably the most important for tonight. Probably the most important thing I do for tonight is I'm an associate research scientist at the Public Policy Center here at the University of Iowa. We have a health policy research program where we have people investigating things from the Medicaid expansion and how successful that has been to school lunch programs and how successful those are, how parents receive them, what kids think about them, how they affect people at home and what they choose for snacks and meals. We also have work going on for dentistry. We look at where dentists are located, whether having a dentist closer or further away is more likely to have you go to the dentist or be accessible for you. We look at how early children get in to see the dentist. Most people believe they should get there in the first year, and we look to see whether newborns are brought in the first year to see a dentist. We do work on things like integrated health homes that take people and make sure that they can see both a primary care provider for their medical needs and their mental health needs. Doing that at the University of Iowa, when we built the new clinic, we integrated a mental health provider there so that our patients could come into a room and see either a medical provider or they could see a mental health provider. We also integrated a chiropractor. So I have this really fun life where I get to play outside in this world that's not academics. I sometimes get to take things I learned here and put them out there, but just as much I look at what I see there and I bring it into what's happening in research. So we get a little bit more of an immediate feeling about what is happening and what we need to ask people. So for example, one of the things we know from our clinic is that we know that under the new Medicaid managed care organizations, our patients with special needs are having a hard time getting the care they need. And we need to advocate harder to be able to get them what they need. We're filling out more paperwork. We've got more people sitting on the phone who can't now provide care because they're on the phone trying to justify why somebody needs a certain kind of medical equipment, a certain kind of habilitation service, or some other special need that needs to be addressed, and that's been very challenging for us. On the research side, we're asking people about that. We're saying, how easy was it to get what you had before? How easy was it to get a prior authorization, to be able to see the same counselor you saw before? So those are the kinds of things that I think are really interesting when we have these conversations, is how we intersect our research with what we do every day.
Hi, everyone. Thanks for having me as well. So Betsy gets to evaluate some of the programs that I'm going to talk to you about that we run, so that'll be interesting to see if we can connect any of our work tonight. My name is Beth Jones, and I used to work for the Department of Public Health, the state health department, for about 12 years. During that time, I worked in maternal and child health, health policy. I served as the department's legislative liaison, so a lot of work with the Iowa General Assembly, and then I also, for most of the time, did outreach and coordination for Medicaid and CHIP, which in Iowa, the CHIP program is Hawkeye, which is a state children's health insurance program. And I would say during my time there, you know, I was fresh out of school when I started working at the Department of Public Health, had a very short time of some direct service background. And one of the things that always was apparent to me were the number of children in Iowa that did not have access to dental care. And there are a lot of people in Iowa that don't have access to dental care, but children in general seem to be something to me that we should meet that need. And for a brief time I thought, maybe perhaps I'll go back to dental school, I'll be one of those public health dentists. And then I had to pull my daughter's tooth, and I decided that was a really bad idea. So interestingly, within a couple of years, Delta Dental of Iowa Foundation was growing significantly, and I had the opportunity to go work for Delta Dental. Delta Dental, I'm the public benefit manager for Delta Dental, which means that I work for the company. I'm contracted to the foundation for about 85% of my time. An interesting thing that most of you probably have never heard of about an insurance company like Delta Dental is that we're a social welfare organization. So we're organized under Iowa Code as a social welfare organization, which means that we give back to the community that we serve. We're the only insurer in Iowa that's still organized under this code. What we do is give to public benefits. So we invest 40 to 60% of our profits every year into our public benefit program, which the primary ways that we give are through dental education loan repayment and through our foundation. So our dental education loan repayment is exactly that. We pay back the debt that dentists incur while they're in school if they choose to practice in an underserved area in Iowa and see 35% underserved patients. When you think about rural Iowa and those health professional shortage areas, that's really easy to meet. Most of our dentists are coming in 50 to 70% underserved patients just by nature of their geography. So it's an opportunity for us to help support the long-term infrastructure to get more services in Iowa. And then the other is our foundation. And that's really why I came to Delta Dental, was that the foundation was focusing on a strategic vision, and there are two major goals by 2020 that we're trying to meet. And they're very aggressive goals. They're 100% goals, which means that we know that people are going to be left behind, but we don't want to say that we want that to happen. So we have a goal for children is that all children be cavity free. The focus is on kids 0 to 12 under 300% of poverty. So we want all kids to not have cavities. And then the other is access to care for homebound and nursing home residents. Huge need in Iowa. When we set our goals, we knew that there was infrastructure and support for children that we could invest in and help push out across the state, but we didn't know anything about what was happening with older adults. And so, you know, one of the health equity things that I see that's a huge issue in Iowa that you don't probably notice as much when you think about communities of color and the vast socioeconomic differences that we have is that older adults enter nursing facilities and within a few months their teeth are completely rotten. And so that's a huge inequity that we have where people are just not getting access to oral health care in a healthcare facility. And it's not the fault of any one organization, it's just a very complex need that an older adult has. And to actually get them out of a facility or get a dentist there to be able to do the work is a complex thing. So those are some of the things that we're working on. We do a lot of coalition building. We do strategic funding where we can fund something statewide. An example of that is a school-based sealant program. We partner with the Department of Public Health, who also gets funding from CDC. So we have, since 2012, taken in a partnership, taken the school-based sealant program to all 99 Iowa counties. So when we started in 2012, we had 22 Iowa counties covered, and they serve all the children, 50% of bring your to school lunch or above in those schools. So those are the kind of things that we do with the funding. We aren't able, we invest about $2 million a year in Iowa, which is a lot of money, but not enough when you think about the large oral health needs. So the other hat that I'm here today in, as you probably saw, is for the Iowa Public Health Association. So the other thing that I do is I am currently the president-elect for the Iowa Public Health Association. The Iowa Public Health Association is a member organization. So we take student members. We'd love to have you join us. What we do is primarily advocacy and education for our members and for Iowans, focusing on issues across Iowa that impact our health. One of those you read about, the Health in All Policies, was one of our priorities. As we move toward Public Health 3.0, focusing more on social determinants of health. A lot of advocacy at the Capitol. Some of the things we've done in the last couple of years is a lot of education of providers and stakeholders on Medicaid modernization. I think this session we're going to see a lot of work on water quality. Huge discussion across the state on water quality going on. And so those are the kind of things that I do in my other side work that I'm here to talk about as well. So I'll try to answer your questions kind of from both aspects, depending on what your questions are. And again, thanks for having us.
Okay, let's open the floor for questions. So a couple people, can I line up people to ask questions? Will you raise your hand? Okay, 1, 2. Can I get somebody over there? Ask a question. Come on. All right, we'll start with the first one.
My mother's a psychiatrist, and she has experienced the same overload on patients that was described. And as a result, she's been forced to move jobs every 5 or 6 years since she began practicing. What steps do you think health service providers could take to minimize that kind of overload on doctors, especially for psychiatrists, family practice docs, and general care physicians?
At the session at the Congress of Delegates this last year, there was a lot of emphasis on physician burnout, and it's prevalent. I know that there's statistically, the statistics about just mental health among all comers, about 1 in 3 people has had a mental health condition, whether it's depression or anxiety, attention deficit disorder, etc. I would argue that the prevalence of physician burnout is much higher. A lot of the emphasis now is on physician resilience and teaching physicians how to be stronger and to combat burnout. I think it's important, for physicians we should take care of ourselves. There's a big emphasis on wellness. Mindfulness-based stress reduction has been shown to reduce scores of depression and anxiety. But part of my approach is, if you think of a relationship between 2 people, an abusive relationship between 2 people, you don't tell the victim to be more resilient. You also have to look at the oppressor. And I think the health system, the way it's geared right now, is the oppressor. I think it's, especially now that it's still volume-based. I know we're changing. We're going to a more quality-based instead of fee-based service, changing from the SDR to MACRA. But if there's still pressure to see more with less support, it's going to be very difficult to address those concerns. And even in the short time that I've been at the university, I've started to feel that pressure of burnout. And I know what it's like. I physically, you can get the physical sense of it. Seeking out allies in your peers, I think, is important. Looking at your organization to support you. One of the things that I did for my job was I said, I don't want to see 25 people a day. I'm going to see 18 people. And to me, that's considered more acceptable. But even at 18, it's still a stress because you have patients coming in with issues, like Betsy said, that have conditions that are related to these social determinants of health. Their access to care, there's poverty, there's a lot of things that they're dealing with that are difficult to address in 15 minutes.
So one of the things that Lisa's talking about that I don't know if you're really familiar with or not is the productivity that physicians get paid under. So doctors charge a certain amount when you're seen. Let's say they charge $50 for that visit. It then goes to the insurance that you have, Medicaid, Medicare, commercial, or you pay it yourself. When it goes to that provider, there's something called a provider adjustment. You rarely get paid $50. What you might get paid is $45 if it's commercial, you might get paid $40 if it's Medicare, and you might get paid $38 if it's Medicaid. If you're a physician working under productivity, you don't get paid on what you just charged of $50. You get paid on what's going to be paid by the insurance. So now what's your incentive if you're a provider working on productivity and you get $45 in your productivity for a private pay or a commercial, you get $40 for Medicare and you get $38 for Medicaid. Well, if you can do the math and you want to make the money, you are going to avoid Medicaid patients at all costs. You are definitely not going to take somebody who cannot pay. That's the system under productivity. The clinics that we operate do not use a productivity model for that reason, because we do not want our providers to be looking at patients saying, how much are you making for me today? We want them looking at patients all equally, regardless of productivity, and the clinic structure supports that. The other thing to think about from a policy perspective, most countries do not have a 40% primary care and a 60% specialty care ratio, which is what we have in America today. They have a 40% specialty care and a 60% primary care. What does that do? It cuts costs and shifts money to primary care providers. Because you know that doc we talked about that's getting $50 for a visit, that's a primary care doc. If I've got diabetes and I go to my primary care doctor, they get paid $50 for taking care of me. But by golly, if they go to an endocrinologist, they're going to get paid $90 or $120 for the same visit, the same amount of care, the same thing. So that's why when you shift that from a policy perspective from 60% specialists to 60% primary care, and you get primary care providers to take care of all the fairly, non-really horribly complex, gonna die tomorrow kind of cases, you can pay them more, have them see fewer patients, and get good care for people right in their own hometown most of the time. So that's one of the things to think about from a policy perspective of how you can stop that burnout, because Lisa's not gonna see 25 then, she can see 16. And she can spend 20 minutes with them. And she can get the support she needs to give them what they need. That was my soapbox. Should I get up? Actually, that's actually a policy truth. That in single-payer systems and other systems, there is that differential in specialty and primary care that's very different than here.
And that's one of the reasons I think that contributes to the fact that there is a shortage of primary care providers in many places in this country. And that's, I think, really become more apparent with the expansion of Medicaid under the ACA, in that not everyone has access to a primary care physician because more people in training are going towards the specialty care.
So one other, enter public health, about 2%, maybe 5% of your life is spent in a physician's office. And so that's where, in those kind of situations, when you look at population-based health and population outreach, community health workers, those people who can be out in the community, doing some of that patient education and outreach that really can make a difference from a prevention standpoint to ease the time of the provider, because we need the providers to be working at the top of their license. And so that, much to what Beth is saying, that's not happening as much as we need it to. And so that's a real true challenge. I think the other thing is there are a lot of opportunities too with telemedicine. We especially when you think about behavioral health, there are another opportunity for providers to be available in all kinds of places at one time. And we don't use it enough yet in Iowa, but there are some states where it's heavily telemedicine.
And do you understand top of your license? So in medicine in particular, in a lot of places, there have been people with a psychiatry degree that have been working in like a mental health center, and they've done everything from evaluating people's mental health to giving medications to calling for the bus to come get them to helping them find housing. And what we're trying to do now is get providers working at the most skill that they have and filling in underneath with other providers. So for example, at our office, when we brought in a behavioral health person, I have a doctor that I told, we're bringing in a counselor to counsel your patients. And he looked at me and said, I counsel my patients. Well, A, you've never gotten a counseling degree, so I don't know how you did that. And I bet it's not that great. And B, we get paid very little for counseling, so let's give it to somebody who does counseling for a living, can do it effectively, and let's get you out of the room in 10 minutes because you've done what you need to, and get to the next patient so you can see the next person. So that's top of your license. You're working at the highest level that you possibly can, and anything that's not at that level, you've got nurse, counselor, social worker, care coordinator, healthcare navigator, all of those people to try to do that with you.
What health issues tend to be more prevalent in low-income and minority households, and how can they be prevented through early intervention and preventative care?
Some of the things that I see in my patient population, the maybe underrepresented minorities, is obesity, especially in children. The other day I had a 7-year-old who has signs of metabolic syndrome, prediabetes. Her 19-year-old sister was diagnosed with type 2 diabetes at the age of 15. When I think about the goal that Beth, you were talking about for Delta Dental, to have no cavities in kids, the first thing I think about is sugar. I think that's one of the biggest monsters or demons in my practice is sugar. I just started a book, Michael Moss, about salt, sugar, and fat, and I don't know if I said it in the right order, but he talks about how sugar has been monopolized. I don't know if that's the right word, but there are a lot of companies, processed foods, General Mills, and other companies that have worked hard to get our kids hooked on sugar at a very early age. And there was a short time in residency after the birth of my first child where I actually wasn't making any money, and I qualified for WIC. And I signed up and received some WIC benefits. And I got the WIC pamphlet. And the food choices, when you go to the grocery store, include lots of sugary cereals, lots of juices, 100% juice. It sounds good, but juice is sugar. An apple is better than apple juice, an orange is better than orange juice, etc. So I see in my practice that sugar is one of the biggest demons that really contributes to obesity, childhood obesity. You have working parents that don't have time to prepare meals, so there's a lot of processed foods. I don't know where it starts or where to cut that. I think that at an early age, encouraging parents to not give juice to their kids. In the past couple of years, I'd seen more kids than I ever would have anticipated, 2 years old with tooth decay and rot, like their teeth were rotting. And they had to be put under general anesthesia to have their cavities, or to actually have their teeth covered until their baby teeth fell out.
In 1996, we did a study, and there was $6 million spent in the Medicaid program for early childhood caries, which is exactly what Lisa's talking about. So $6 million spent to pull kids' teeth out in the OR. And when you look at the claims for those kids, you see an OR visit and you see all their teeth getting pulled, and you think, why would anybody have to do that? I will add to this, Natasha Askelson in the Public Policy Center, who does a lot of work on food and nutrition and health, would say, I think if she were here, one of the things to think about is the reason that people who have limited access to resources use processed foods is because they know that their families will eat it and it won't go bad. So if you don't have a lot of money, you're not going to spend it on broccoli if you don't think your kids are going to eat it, or you've never been told how to prepare it so that your children will eat it or your family will eat it. Sugar is a big problem, that's true, but parents want something that their kids will accept. And the other thing that people struggle with in this area from a policy perspective is when you look at WIC, is it fair for us to limit the choices people have based upon whether they can pay for it themselves or if they're on a public program? So yes, it would be lovely to stop people from spending their money on WIC if we believed that we had the right to impose those choices upon them. And where does that put them as a member of society when we begin to be that limiting in what they can and cannot have? So I think those are just things for you to think about as you move into the policy arena, how advocates think about what we're saying to people when we start to take the giving of resources and link it to very specific actions.
I would also say it's what community they live in. What do they have access to? So for a lot of people, the only grocery store nearby is a QT or a Come and Go. So what options are there for somebody to buy? I think also looking at what Betsy said with food choices, families, if you can drive through McDonald's and order off the dollar menu and feed a family, as opposed to go to the grocery store, not knowing how to prepare those fresh foods is a big piece as well. I think also just understanding the everyday stressors, that people are under an enormous amount of stress, and it's really about crisis management. What's the crisis of the hour that they need to get through? And oftentimes it's not about, they just want to make sure the child is fed, that their family is fed, and that they have a meal. And they can't think past to whether or not it's the healthiest choice for that child at the time or for their family at the time. And so, you know, how can we build systems around people that give them better access? And I think that's what you get from some of the information on social determinants, is that, you know, when people are in an environment where they can get out and have access and learn those things, our expectations are sometimes unfair as well. One of the things I've been learning about a little bit, and it's actually a professor at the College of Dentistry that's studying self-determination theory in relationship to early childhood care, is giving people a choice. So reminding people that, you know, you shouldn't put juice in the bottle is just, in a way, a shaming that you're doing something wrong. So how do we give people the choices? Could you give your child half as much juice in the bottle and continue to reduce that every day for a week or 2 weeks until you no longer have juice in the bottle and it's just water? And so there are a lot of strategies that, as public health professionals, you know, we really try to use to help educate and inform people about what options are out there and how to make some of those choices that maybe are not so, that can come across so shaming. And I think that's exactly what Betsy was saying about with WIC and other food programs as well. You can only limit so much because you're still trying to, you know, give people a choice.
The other thing that they've talked about that's fascinating to me from a policy perspective is right now people get all their WIC dollars at one point in a month, right? So there they are. They want to get them used and get things bought, and they're trying to get things that they can keep. They've talked about making it so that every week a certain amount goes into the WIC card so that they're more limited in how much they can spend each week. And that's a huge issue from a policy perspective because they're not sure that that change would really help, and they think it could limit people if there are weeks when they really need more and then they might need less. So that is really interesting to think about, just the incentives of getting everything at once or getting it once a week. You know, I think it's fun.
There are a lot of really good points have been made here. I just wanted to comment on a couple. We've talked a lot about dental care and for children and adults. And one of the things I've learned working at the free clinic is that many people will put dental care below health care. They will try everything they can to get their health care needs met, but dental care comes at the very bottom. We see people who have not been to the dentist for a cleaning or an exam for over 10 years. And it's not because they didn't want to go, it's because they had to make choices on what they could afford. One of the questions that someone asked, one of you asked, was the most rewarding part of my job, and I want to speak to that just real briefly. one of the reasons I've worked at the clinic as long as I have is it has given me an incredible sense of perspective of how truly fortunate I am. I grew up in a middle-class family, and I don't know the lives of any of you, but I would bet many of you don't have to make choices every day about whether you can go to the grocery store and feed yourself and your family or pay a medical bill. And this is, I'm sure all of you have thought about this, but it's something that humbles me every day, and it keeps me doing what I do, and it keeps me passionate about what I do. The people we serve at the clinic are hardworking people. They have families. They have just had a lot of bad luck in their lives, and a lot of that luck is because of racial inequalities and racism in this country, which is alive and well. We serve a disproportionately high number of people of color at the clinic. Last year, 38% of our patients were identified as Hispanic Latino, about 20% as Black African American. We too are seeing a growing number of Spanish-speaking people. We are seeing a lot of French-speaking people, refugees use our services. So I think that, and again, and almost the majority of our patients are very low income. Poverty, from what I've seen, how it has affected the thousands of people that have used our services, it has an incredibly powerful effect on your mental state and your physical health. Someone mentioned here there's a higher rate of chronic illness among people who grew up in poverty and who live in poverty. And the stress of trying to live from day to day and balance the incredible number of barriers that people face just takes its toll. So poverty and access to health care are directly related, and from what I've seen.
That's the next question.
Okay, so especially for like the free clinic, how do you determine eligibility? Is it just an honor system, like you don't have insurance, or is there a procedure for that?
We see people who don't have any insurance or who fall into the group that I called underinsured. Well, people who have insurance, we let them know that our services are limited and that we see people who have no other options. Now, again, there are exceptions to that. If people have health insurance and don't have any dental coverage, we'll see them for a dental visit, etc. Now, the one exception to that rule is that another service the free clinic offers is we are considered Johnson County's sexually transmitted disease clinic. We will see anyone for a sexually transmitted disease check, regardless of whether they have insurance or not. And that's because some people understandably may not feel comfortable going to their primary provider for an STD test, so that is one exception to the rule. But 98% of the people we see are either uninsured or underinsured. And we do not ask them for documentation of that, but we take their word for it.
Next question. Can I get somebody over here so I don't have to go back and forth? All right, here we go.
Sorry.
You don't have to apologize. You get bonus points for asking a question.
Earlier, it was briefly mentioned, like, in regards to another point, that the term single-payer healthcare. What do you guys think that we should move towards that as a goal? Thank you.
So I will tell you that some of the providers that I've worked with would love to see that, because it would cut down on the amount of paperwork that they believe their offices are currently doing, and we've talked about that. There are some inherent incentives in a single-payer system that everyone needs to think about, and that we need to be thoughtful about how it would change. And so one of the things that would happen would be right away we would be thinking about how to shift that percentage of primary care to be larger, because you would want to have a lot more people who are lower paid, right? A family practice doc in Iowa makes $180,000 to $125,000. They're not poor. I mean, they're under stress, but they're not dying of poverty either. These people make good money. We live well. But if you are a cardiologist, you're making $450,000. So I can pay a lot of primary care for a few specialists. So that's one of the changes that would happen. In single-payer systems, there are different incentives, though, because you don't pay every time that you go in. You're more likely to go in, but you're also more likely to perhaps overuse the system. So that's something to think about. In some of those systems, there's rationing because you have a certain amount of resources and you're not going to give everybody what they need right away. You may make people wait a little longer. I had a friend whose father needed heart surgery in Canada, and that's a very good system. But they lived in Windsor, if you're familiar, that's by Detroit. The heart center closest to him was actually in Toronto. So his whole family and he had to travel for him to get open heart surgery to Toronto. We're lucky here in America because we don't travel very far if we can get the care. It's just that we may not get the care. So I think it's a great way to think about doing it. I would really love to see that, actually. And I don't know, you would probably love to see it.
I think it would be worth a try in this country to see how it worked. The current system under the ACA, I think was a step in the right direction. The Affordable Care Act was a lot about health insurance reform. It's not the same as universal health care. Again, I think the ACA has a lot of good parts to it. The reforms that insurance companies had to put in place, especially in particular that they can't deny people with pre-existing conditions insurance. If someone gets sick, they can't cut off their insurance. I think these things were very good. The Medicaid expansion, I think, was a good step. The subsidies for low-income and families, I think. Unfortunately, I have no idea what's going to happen to all of this now with the new administration. There's so many questions now. It doesn't look really good as far as continuing what's already started, but obviously we'll just have to wait and see. A single-payer system is imperfect too. There's no country that has a single-payer system that doesn't have problems and challenges with it. Waiting lists, I know, for specialty care in particular. But I, for one, would be willing to pay some more tax dollars to give it a try. And overall, I think, although the ACA has cut the number of uninsured in this country by 20 million, it was 46 million uninsured before the ACA, and that was cut by 20 million. That's a tremendous step in the right direction, but that's a lot, that's millions of people who remain uninsured. And that doesn't include people who are underinsured. So obviously we have a long way to go in this country. And I would say that just personally, I can't speak for the free clinic, but personally I would like to see it tried in this country.
So there have been about 2 or 3 other times in America that the single-payer systems have come up. I don't know if you've looked at the history of that at all. And 2 of the times that it came up were right around the World War. So all that anyone had to say to defeat it was, wow, that's socialistic, that's like Germany, so guess what, we're not going to do that. And that's the problem that we always have whenever we talk about single payer, is politically it doesn't look democratic or capitalistic. It looks very socialistic, and we're not socialists. So we need to think of a way to do that. Secondarily, I want you all to think tonight when you go home through this seriously, because what happens if this becomes a single payer system is a lot of people will not have work that are in the system now. Our office currently employs at least 1 office person, 1 nurse provider, and then a shared care coordinator for each of our providers. We would not need that if we did not have to bill 5 different types of insurance and keep track of electronic payments and worry about doing prior authorizations and getting all the permissions to get patients what they need. We wouldn't have the insurance companies and the mechanism that we have today. A single payer system most likely results in bigger government. That's also one of the keywords in policy that makes us hesitant to think that it would work. So yeah, I'd love it, but I don't know if it would ever happen. I don't know about dentistry if you want a single payer system.
Well, we're not even coordinated with health at this point. So I don't know. I don't know if it's the answer. I would say what I think the goal should be is to have people covered and have people have access. And I don't know that I don't think our current system is doing the best job of that. And I don't know that that's the answer either. Unfortunately, there aren't enough people in the world who are altruistically want that to happen. And if we all wanted that to happen, we could make it happen. It becomes a fight about policy. It becomes a fight about who owns what. And really, if we all focused on the patients and making sure that every patient had access to care and had coverage for that access to care, I think we could come up with a solution, whether it be single payer or something else.
I'm also in favor of the theoretical environment where people had equitable access to care. And I acknowledge all of the obstacles that are currently being discussed. But with the new administration and what I'm picking up from reading either the New York Times or NPR, those are my go-to sources for information quickly because I don't have a lot of time to read. The trend now is privatization of Medicare. We're already experiencing privatization of our state plans. I think there's going to be less government oversight. I don't know how it's going to change. I'm trying to read up on the new Secretary for Health and Human Services, that is the nominees, and their historical political leanings have been more towards privatization and less towards universal care. So I think that in theory a lot of us want this, but it's going to take at least another 4 years for us to work on something that we can bring to provide better care.
There's a universal health care, just to clarify, and something I didn't realize. I was doing a little bit of reading about it, but it doesn't cover everything. Generally what it refers to is just basic medical care. And several of the developed countries who have more of a socialized medicine model people have to pay for specialty care. So it doesn't cover everything. And I think that sometimes people get scared when they hear the term universal health care, that taxpayers are going to have to pay for everything. And they pay for some, but it's not for everything. Again, it's just basic. That's my understanding. It's a basic care.
For example, in Britain, because of some of the wait lines, they established a sort of second tier of healthcare where people could pay to go outside of the wait line so that they could get care. In China, where it was completely universal, but it was a universal insurance, so people bought an insurance through the government, and then the government bought the insurance, and then that insurance paid for care. They also started what they considered to be more of a privatized insurance so that people could buy into it if they had the money to do that. So it seems like no matter which side we enter it from, we do sort of get into a two-tiered system where those with money can pay for the extra things they need, and those that don't have it don't get access to those.
This question is in response to one of the points you made, Betsy, about how your clinics in Amana and Tiffin have moved from a fee-for-service to a value-based model of care. I was wondering if you could explain operationally how that's working out, because I'm thinking about a truly capitated model, and if you're working in a clinic that is smaller and in capitation, if you're relying on a per member per month basis, just to understand how the process and how you guys are fulfilling that.
So if you've heard about accountable care organizations, or ACOs, we belong to the Unity Point, which is the St. Luke's and Cedar Rapids ACO. A small clinic can't really survive on per capita or getting a per member per month payment because we're very bad at actuarializing our patients, and because we're in a rural area and take everybody that comes, who even has some remote method of paying, and sometimes that doesn't, we could end up with a lot of chronic care patients with high need, and that could hurt us a great deal. So we're in a level 1, which means we're a full participant in an ACO, accountable care organization, that's contracted with Medicare and private payers to provide a high quality product at a per member month. It's actually at a budgeted amount. So what the insurance company does, it says, Mrs. Johnson's going to cost us $1,200, Mr. Smith's going to cost us $1,200, and Mrs. Jones is going to cost us $2,000. So we're going to give you a budget of $1,200, $1,200, and $2,000, which is going to give you $4,400 this year. And if you don't spend all of that on them, we're going to let you keep half the savings, and you're going to give the other half to us. But if you spend more than that, you're going to pay for that extra. The part when I get to keep it is called positive risk. The part where I pay it is called negative or downside risk. In the ACO, what has happened is the ACO is withholding some of that payment over the years when we're getting positive reimbursement or we're on the positive risk side, so that if it ever goes on negative risk, the ACO as an organization will pay it. We won't have to as an independent practice of providers or a small practice. So that protects us. They give us a big umbrella. To be in that contract, though, we have to provide to people high-quality care, which means that we need to make sure that at least 80% of the people that we have in our practice with diabetes get a hemoglobin A1C test, an LDL or a cholesterol test, and a BMI every year. We have to make sure that we have a certain percent of our children who get vaccinations. We have to have most of our people get flu shots. We have to make sure that every 5 years they get a pneumonia shot. There's all sorts of measures like that that we're held to. If you have depression and we put you on a depression med, a quality measure is whether we see you back in 30 days to reassess whether that medication is working for you or not. If you're in the hospital and you get discharged, a quality measure is whether we saw you within 7 days of being discharged. If you go to the ER, we're supposed to see you within 3 days of going to the ER. So those are the kinds of quality incentives that are being placed upon us, and we can't stay in that ACO agreement if we don't do that. And I'm sure you guys, well, maybe not at Free Med, I don't know how you work, but you're probably seeing a feed.
One of the things that I'd like you to think about is how does the value-based model respond or deal with the social determinants of health? What about my patient who works on the line in the meatpacking plant that can't take their insulin and can't get that A1C down to 7%? I can be penalized for that. I won't get an incentive for that. I don't know that the new system, I think it's better than what it used to be, but it's still not accounting for those social determinants of health. Access to vaccines. When I worked in West Liberty, my patients that were recipients of Medicaid or the state plan were not able to get their vaccinations in that clinic because we didn't have enough space for a refrigerator to house those vaccines. And if you can't hold the right amount of vaccines at the right temperature, if you administer a vaccine that isn't controlled, you could potentially, that vaccine episode would be canceled, meaning they would have to get the vaccine again. So rather than lose money, the clinic was losing money for these vaccinations, they stopped making vaccines available to all children that were recipients of Medicare. So in an area like West Liberty, the closest place to get vaccines if you lived in Muscatine County is to go to Muscatine. If you're already of decreased means, your mother or father would have to take an extra day off of work, may not get compensated for that, may get points for that, and if you accumulate so many points, you get fired from your job. Do you see where I'm going? So there's a lot of aspects of care that is not accounted for in this new model, in this value-based model.
But it's important to understand that the vaccination choice was made by the clinic. Our clinic holds those vaccines. Those vaccines, we don't pay for those vaccines. Those are done through the Vaccine for Children program. It's completely free. The children come in if they're in Medicaid or on CHIP, or if they're Native Indigenous peoples, they receive those vaccines for free. All we had to do was buy a refrigerator off of the line at any store. It can be a Samsung, it can be anything. Just has to get to a certain freezing level. We keep it there. We got the thermometer to make sure that it was the correct temperature from the state of Iowa. They gave it to us for free so that we could keep those vaccines for kids. So, you know, I think sometimes, Lisa, I'm not trying to argue with your point, but I think we need to be very clear sometimes when we as physicians' clinics make choices because we want to make money, as opposed to because we want to serve people. And that's, you know, in our environment today with capitalism, that's one of the things we all try to do. But we can make choices. We lose money every day in the laboratory in our clinic. Every day, I've got a nurse, a lab technician in our laboratory. We don't draw enough labs to make money on that, but that's how you give people comprehensive care. I don't want anybody with diabetes in my clinic to have to go to a lab to get their blood drawn that's 30 miles away so they can find out whether they're in compliance. They can do it at our clinic. the day they have their well visit, and in 30 minutes we're going to tell them how well they're doing, and that doctor's going to go out in the room with them and say, you know what, Miss Jones, you're not compliant. We need you to get your stuff down. Let's figure out who you can see. So remember, immediacy of some of these things is really important. When Dr. Momini comes and tells you you didn't do what he said, it feels a lot worse than when somebody calls you on the phone like 5 days later.
And I would also add that from that value-based piece, that's where, again, you can talk about people working at the top of their license. So that's where those care coordinators can come in. A lot of the ACOs are starting to build this model, and they can partner with public health, but they can also have those care coordinators in their offices that can go out and get outside of their four walls. So if there's a plant like that where there are a lot of patients that can't get in, you can have your care coordinator go out, make sure that they're getting what they need, do some of that education, maybe talk to those employers about why that's important. So that's where you can get to that level of the system that often we miss, that we talk so much about the direct service and what's really expensive, but those things are not terribly expensive. Yes, they require some drive. They require the right kind of person to go into a facility and say, you know, can I talk to your HR person? How can we help? They require clinics to have extended hours outside of the traditional 8 to 5, which can obviously contribute to burnout as well. But there are some things where we have to think more non-traditional and not just focus on that direct service that happens in the provider's office and how we get out into the community. And that's where population health, you know, with the ACOs and that population health management could really make a difference. And, you know, it's things like teaching people how to use a knife. People don't know how to cut fruits and vegetables, so how do we expect them to eat the fruits and vegetables? Those are the things that we can be doing, and there are people that do that already, and obviously I'm a public health person. There are people all over the state that do those things already, that we just need to do a better job of selling our role as public health professionals and working with those ACOs and those providers. And I mean, I've been talking about that for 4 or 5 years. As we saw this change coming, that's where public health needs to be. We need to go into those provider offices and say, here are the things that we can do, and here's how we can help you reduce your costs. So those are things that I think as we see our system continue to change and mature, hopefully there's not too much that tears apart all Medicaid expansion that's happened, that we have to see happen to reduce those costs, because we're spending all kinds of money on the back end, and we can save a lot on the front end. An example are sealants. Sealants are a thin plastic coating that go on a child's tooth as soon as those teeth erupt. So they're 6-year molar and then 12-year molar. You just go in, clean the tooth, put the plastic coating on, and then the sugar and all of the bad foods can't get in and cause decay on the tooth. They cost pennies. They're very, very affordable. They're very inexpensive to place on the tooth. And then you don't have to worry about that care on that molar for a really long time and stay for quite a while. So those are the kind of things that, you know, we need to get out and do, and those are done in schools. That's the program that we operate, runs those in schools today. So those are the kind of things that I think can really make a difference when you're talking about value. How do we get outside of our 4 walls and get out into the community and deliver services?
And I think that's one of the things that Lisa brings up with workplaces is that we're tending to seem to swing into the area where we believe that factory owners and corporations are going to care about their people. And I think she gives a good example of how, you know, somebody who's demanding that they get the time to give themselves an insulin shot in a workplace might actually get fired, right? So then they've got nothing. So how do we impose that without using some sort of regulation to make it happen? I mean,
our medical director has had to write notes, letters to employers that state that the patient needs to take the time out to have an insulin injection or needs to have a snack. So without that note, they're not able to do it. So.
Yeah, and those are just really tough environments. Do you know if they've ever had ramifications back on them because of those notes?
I don't know.
Yeah.
I don't know.
So I'd like to ask question. We've talked a lot about the challenges and some of the problems, both in terms of accessibility and affordability. Could you just think about some policies or programs that you know of that address some of these issues and that have had a positive impact, or that you would like to see expanded because you think that they would have positive impacts?
So I'll give you all a chance to think, and I'll talk about one. So we've talked a little bit about oral health, and I've talked a lot about care coordination services that could be provided. And so one example in Iowa is called iSmile. iSmile is a program for children that's run by the Iowa Department of Public Health. There are iSmile coordinators, which are dental hygienists that are located in every maternal and child health agency in the state. So there are 21 agencies across the state. And what they do is provide care coordination service primarily for kids on Medicaid, Hawkeye, and then uninsured. There is a small for statewide pot of funds that goes to the Department of Public Health as well as Medicaid reimbursement for their service. So there's a small appropriation that they receive that goes statewide, and then because they're in maternal and child health agencies, they're able to bill for some of those Medicaid services. So what they do is exactly what I've said to you, and they do it for oral health. They coordinate care. They work with the dentists in the community, find out if the dentists are taking new Medicaid patients, and if they are out of school-based sealant program, doing a varnish program, doing outreach like in a health fair. They assess the child, and they take those high-need kids and make sure that those kids get into the dentist. The program started in roughly 2006, and the data has shown that we've doubled the percentage of kids in Iowa, Medicaid kids, that have seen a dentist. So it's a significant number of kids that have received care. We're getting more prevention, less severe. So when they do those assessments, they're also seeing less severe decay. And in addition, because of the work of iSmile, we're now seeing there's a couple pilots for iSmile Silver, so trying to do something for older adults. And then also they've implemented some policies. So every child entering kindergarten has to have a screening, an oral health screening. And every child entering 9th grade has to have a dental exam. Obviously, kids aren't excluded from school for that, but we get about a 90% rate of kids who are getting a screen or seeing a dentist at those ages. So those are just some opportunities to do interventions that are much lower cost, and we're getting services to those kids that otherwise wouldn't receive them.
One of the activities that I participated in when I was in West Liberty was I applied for a grant from Reach Out and Read, Iowa, and we were able to secure funding, $3,000 for the start, to pay for books that were provided or subsidized by Scholastic. So they would charge approximately $1 to $2 per book, and I would order $1,000 at a time. And the books are given to children at their well child visits starting at the age of 6 months up until the age of 5. So every well child visit, children are usually seen at 2 months, 4 months, 6 months, so they get their first book at 6 months. That correlates when they have their best vision at 6 months. That's when they can look at a line of people and pick out their parents just from sight. And they're very attuned to seeing faces, other kids' faces. They really get excited seeing other kids' faces. So we use board books at that age. Then they come back at 9 months, 12 months, 15 months, 18 months, age 2, 3, and 4, and 5. So I was very proud to be a part of that program to bring it to West Liberty and made sure that it was also culturally and language appropriate. I was able to get books in Spanish and in English, since those were the primary languages served in my clinic. And that program still continues. They still have a lot of books to give out. And my clinic now at the Southeast Iowa City Clinic at the University of Iowa, we also participate in Reach Out and Read, and the University Hospital Family Medicine Clinic also participates. So encouraging literacy from an early age is very important. Encouraging using books and reading as opposed to tablets and phones. Many times parents and family members are very excited when their 18-month-old can toggle a touch screen. And I'd really much rather that they can turn the pages of a book and that they know what to do with the book. Many of the obstacles that I see when I take care of my Spanish-speaking families is that the parents may not feel the obligation to teach their children. They feel that maybe that the teachers are there to teach the children, that the parents shouldn't teach them. I encourage them at an early age, you are the first teachers of your child. The more language and words that they hear in early ages of life, the more vocabulary that they will produce later on, and the more apt that they are to become successful at school. Literacy is a big problem. It's another obstacle to healthcare. It's a part of the social determinants of health, and that's one that I advocate for passionately in my patients.
So we had two programs that we looked at that were very helpful. One was called the Integrated Health Home, which is currently operating Medicaid, and it takes community mental health centers as integrated health homes. They either hire primary care providers or they connect with the primary care providers to make sure that people who are primarily being seen there for mental health issues of some sort are connected to primary care and have their primary care needs met. What that did is it cut down on the number of emergency visits that people had, because they had care for the things that tended to throw them into the emergency room, and they knew they had access to a provider if they needed it. So if they got sick in the middle of the night with a fever, they didn't need to go to the ER right away. They knew in the morning they'd have a provider they could go to see. So it cut down on ER visits. It also helped to keep them on their medications. That program was very successful. The other one was the Medical Health Home, which was a program that rewarded primary care providers for counseling patients, particularly those who are what we would call ER frequent flyers. So people who go into the ER a lot and utilize it all the time, sometimes 6 times in a month, the primary care providers would bring them into their office and talk to them about what the appropriate use of an ER would be and what options they had that are way better than an ER, like coming in to see their primary care provider or practicing preventive care so that they don't have that problem. And we cut down, the state cut down the number of ER visits that people had, and on the back end of it then, the number of hospitalizations, because people often enter the hospital through the ER. So those are two pretty successful programs that the state's put into place.
I wanted to mention that one of the things I've been glad to see are more grants that are offered to do preventative work, as in addition to grants to treat people for health problems they already have. One of the things I've worked on at the clinic over the last year is finding grant funding so that we can work with our patients to prevent diabetes, not just treat diabetes. And over the last year, we've received 2 grants that have allowed us to start this. So I've been encouraged by that opportunity, and hope that continues.
So I'll leave you with this thought from me. In the 2 clinics that we have, I do all the financials. And I get really excited in the wintertime because the flu comes along and we get a lot of money for the flu. So remember that the way we pay providers right now rewards them not for keeping people healthy, but for keeping them having to come in because they're sick. So every time somebody gets sick, I ring a little bell in my little bank account and get really excited about that. So just think the system we have is not rewarding well behavior at all.
I think we have time for one last question.
No, go ahead. I just wanted to talk about cultural competency within the healthcare system, because you're asking people to change what they're eating, to change how they're interacting with their kids, and especially in a workforce in Iowa, especially in levels of like leadership, like doctors, a lot of the people you're interacting with are white. To be someone who's going to the doctor and getting told by a bunch of people who don't understand your culture necessarily how to eat and how to raise your kids and what we can do. And I mean, and this can even be translated into college culture. Like, I remember going to the doctor as a college student and then being like, well, how much are you drinking? And I'm like, oh, not that much. And then, you know, and the doctors are saying, good, you shouldn't drink very much. You should only drink 3 glasses a week or whatever. And then you go back into your culture and where you're living, and it's like everybody's drinking. It's, you know, and I'm just kind of wondering where we can meet and bringing people, getting a realistic idea of what it's like to be in another person's shoes and what we can ask and how we can get people to change these like really meaningful lifestyles.
I think it's important to consider cultural competency as a pathway and not an endpoint. It's not a place that you get to, you get a diploma. Congratulations, you're culturally competent. It's a constant lifelong learning process, and one that I am in every day with every patient. Even though a patient may speak the same language as me, or we are similar in appearance, we're very different. And I start first by giving people time to tell me about themselves. I kind of have like a system that I use when I meet patients, you know, get through the initial niceties, but I ask them some questions that really allow me to get to know them. I don't like to come from the paternalistic sense and say you need to drink 2 drinks a day and stop smoking and you should really do this. I'm pretty diplomatic about things. Sometimes I have a nice way of saying it. But I ask people, you know, some of the most important questions are, who do you live with at home? I want to see who's in their surroundings. What's your work schedule? That allows me to know, are they working first shift or second shift? Where do you live? Do you live in an apartment? Do you live in a trailer? Are you bunking with a friend? Who's in your social support system? Who's your social network? One of my favorite questions is what brings you joy? That gives me so much more information about somebody than what I can read on the paper where they fill out their past medical history or their parents' medical history. Learning about their hobbies. I have a patient who paints barn quilts. I learn a lot about my patients just from those few questions. And I try to meet them where they're at. I ask them, you know, today I had a patient, a 26-year-old obese woman who wants to lose weight. And in my head, my thought is, okay, you need to eat right. You know, we all know this. Eat more fruits and vegetables. Everybody knows this. Exercise. Everybody knows this. But I want to know what she's done. She made significant changes to eat better. I didn't feel like I had anything else to offer her. So I let her tell me. She was using an app to track her fitness. She is a single parent to 2 children. She had done a lot of research on her own. She goes, I'm actually interested in a sleeve gastrectomy, which gastric bypass. And I thought, well, you know, where is she at? Has she gone through the necessary steps that I think would be important for her before she even talks about surgery? Because usually surgery is a big lifestyle change. So I think a good provider meets their patients halfway and listens and learns where they're coming from. And that's part of the pathway of cultural competency, if you want to say that, or proficiency. It's learning about your patient and letting them teach you.
Yes, thank you, Lisa. Or Eleanor, I'm sorry. That was Lisa. That was very well put. I wanted to give an example. First of all, whoever asked that question, it's a really, really important question. You have to balance where someone's coming from with what you need them. You need them to get better. You need them to feel better. So it's a balancing act. But one of the things, when our medical director started, one of the things she talked to me about was how she was hearing over and over again from many of our Spanish-speaking patients, and I don't mean to stereotype, this wasn't all of them, but she was hearing over and over again that they stopped taking their medicine that they were supposed to take every day because they were feeling better. And it didn't make any sense to them to take the medicine to continue to feel better. They started feeling better, and so they stopped. And it was a real educational moment for her to be able to talk to them about why they're feeling better. It's because they're taking their medicine every day. And I really like what you said. It's an ongoing opportunity for providers and for patients to work together to get to the end goal of better health.
We've run out of time, so please help me in thanking our panel.